Good evening, ladies and gentlemen. First of all, I must thank you all for taking out time on a Sunday evening, which is obviously a time for the family, for all of us who works in healthcare. However, but you all people took time and came on a very short request. So we welcome you all to this inspiring TED Talk where we have Dr. Sudhir Diwan and Dr. Neeraj Jain with us. And this TED Talk is being hosted by our flagship hospital, which is coming up in Indirapuram as Yashoda Medicity, which has also now become the talk of the town in healthcare industry. We are also delighted to have such an esteemed gathering of healthcare professionals from Delhi NCR, who are thought leaders and distinguished guests with us tonight. Over here, I take this opportunity before we formally start this TED Talk. We are waiting for some more people to join us, including our CMD, Dr. P. N. Arora and Dr. Upasana Arora. I'll just take this opportunity to introduce you to this Yashoda Medicity, which is going to redefine the overall healthcare excellence in the nation. It is going to be a holistic healing facility with integration of evidence-based, safe, ethical, modern medical practices and indigenous medical systems to deliver effective and sustainable patient outcomes. It is going to have an unparalleled infrastructure wherein, first time in the world, the emergency medicine department will be well equipped with MRI, CT scan, heart and stroke command, which would be directly connected to cath and DSA lab. It's going to have a 252 beds ICU in phase 1, along with 650 other beds, all modular ICU beds, 20 operation theaters, 10 endoscopy suites, and a dedicated children's hospital having all pediatric subspecialties. And this is all going to have an inspiration and understanding of JCI standards. In terms of the technology, it's all going to be cutting edge, wherein our Yashoda Cancer Care Institute will have first of its kind unique combination of latest Electa MR Linac, variant Edge and Ethos Linac. Nuclear medicine will be supported by SPECT CT and digital PET CT, wherein we'll have all diagnostic and therapeutic possibilities of the department. In addition to that, in all specialties wherein we have the possibilities to have influx of robotics and AI, be it solid organ surgeries, orthopedics, or neurosurgery, we will have then amalgamation of robotics with us. But nevertheless, it's always said that it's always man behind the machine. So we would be having best of the talent of Delhi NCR and other parts of the country to cater the services to our patients, along with compassionate staff prioritizing patient well-being. And you'll be happy to know that this is going to be the first hospital in India, a green building which will be certified by LEED. Rest other in India are till date are being certified by IGBC, which is Indian body for green buildings. Good evening, ma'am. Ladies and gentlemen, we have our Managing Director and CEO, Dr. Upasana Arora, with us. And with that, I'll just quickly introduce She's actually doesn't need any introduction to all healthcare professionals. She is now, apart from being the managing director and CEO of Yashoda Group of Hospitals, she chairs the healthcare sector vertical of SEPC, which is Services Export Promotion Council. She is the national chairperson for Indo-American Chamber of Commerce. She also chairs the Delhi chapter of Special Olympics, which is a very noble cause wherein specially abled children and people are into Olympics. As well as she is the national treasurer for Special Olympics Bharat. She also there as the co-chair for FIPP Medical Tourism Committee, vice chair for CII UP chapter, and various other boards. You name it, she is there, including NABH. She carries a vision to channelize Indian healthcare sector services in an ethical and cost-effective manner with an emphasis of maximum international exposure and reversing the brain drain, which has gone to overseas, to the West, to the Europe, to let them come back to India. This will in turn get foreign exchange to our country and will strengthen the economy. The new budget was there yesterday only. So I invite our MD and CEO, Dr. Upasana Arora, on stage to formally start this program of the evening. Dr. Upasana Arora, ma'am.
Good evening, everyone. I'm so happy that today Dr. Diwan is here. I think 1 year back we met in USA and we were talking about how we can, start pain management in, already Dr. Neeraj is working with us, but Dr. Neeraj is big fan of Dr. Diwan. So he said, I would like to start something with Dr. Diwan in India. So now that glorious moment has come and Dr. Diwan is with us. So big round of applause for him. We are lucky that Dr. Neeraj is with us and we are already working on pain management in many ways, and Yashoda is really lucky to have best of the best doctors with Yashoda. And it is not institute, it's a family. Whosoever is working with us from last 18 years, they are with me. And we always talk to each other like a family member. If somebody is having any issues, we are then and there solving that. There are no many, paperwork, no HR is involved, not lots of notices are going on anywhere. It's like you have this problem, we will solve it. And in that same manner, we want when Dr. Diwan will associate with us, you will never face any problem. My all team will tell you that they never face any problem. Any problem you face, Amit? Tell me. So these people, I think, and we are going to start this TED Talk. First, I would like to invite Dr. Neeraj, and then definitely we are eager to listen to you, Dr. Diwan. That was a wonderful evening we spent together in that beautiful restaurant. I don't know which Michelin star was that. I am not very fond of food, so I am not very much aware also. This Michelin star and this is a big chef. Rather, you were telling us what we should eat. So happy to have you here. Now I will tell you what you should eat here in Taj. Thank you and welcome. And welcome all those who came here in the Sunday evening, which is actually relaxing evening. Nobody wants to go out. But thank you so much for coming here and listening this actually knowledgeable and energetic talk, because Dr. Neeraj is very energetic. Thank you.
Thank you, ma'am, for that warm and inspiring welcome to all our guests and our TED speakers. So now I would request ladies and gentlemen, we have our CMD, Dr. P.N. Arora, with us. Thank you so much for joining us, sir. Now, to give us an insightful introduction to Yashoda Spine and Pain Management Institute and highlight the vision that what we carry through this Center of Excellence under Dr. Neeraj Jain, I invite our HOD Anesthesia, Dr. Sunil Sharma, who is having almost 25 plus years in anesthesia to take this forward. Dr. Sunil Sharma, please join us. Thank you. After this TED talk, he will be formally announced into pain management.
Thank you. My greetings to Madam and Sir, and I welcome you all here for this TED talk. As I have been invited here to introduce Dr. Neeraj Jain, who does not at all need any introduction in this gathering. He is my mentor, and whatever I am in pain today, I am because of him. So Dr. Neeraj Jain is biggest stalwart of pain medicine in India and abroad worldwide. He is internationally acknowledged pain and spine specialist. He is director of Yashoda Institute of Pain and Excellence. He has got so many national and international presentations, lectures. He is an excellent teacher. He is a teacher par excellence. Virtually most of the pain specialists that are practicing here are trained by him. And he has innovated so many techniques: NJ balloon epidural neuroplasty, endomesoplasty, and this NJ transdiscal ultrasound for spinal canal. This innovation has been done in Yashoda Koshambi, madam. Ultrasound that we did first time in Yashoda Koshambi. So, first ever in the world. That was done in Yashoda Koshambi. The patient was my friend. Pankaj ko kiya tha. So now he has got a lots of interest in mentoring pain specialists and conducting numerous live pain workshops. So I request Dr. Neeraj Jain to please come on stage and start a TED talk on a vital subject: pain relief is a human right. Sir, please.
My dear friends, sir and madam, and Prof. Diwan sir, who has come all the way from USA to enlighten us, enrich us, and give us the wisdom, how best we can manage with these subcontinental MSCs. So we're going to talk about that during the daytime. I'm so happy there's so many good friends around who are doing good pain work. So I wanted most of them to be around and take away. There's a lot of takeaway from today's talk. It's not very scientific, but yes, we had a mix of a motivation to do with pain relief is human right, and how much it really entails and how much it is required to talk about it. Why we have to talk about it is because this is the commonest reason why a patient comes to a pain clinic, and in the hospital for that matter. And if you don't have a pain clinic in the right hospital, obviously it has become a certification issue now. So let's talk about an important topic today: pain relief is human right. I'll take you through this. This is a pictorial presentation, but yes, there's a lot of message around. Pain is as old as mankind. Yes, it's still mysterious. And we are trying to fight it out for ages together. Now we have tools in hand, and we can really do justice for these patients. It has become a burning problem of today's times, because the digital world and these young kids, young boys and girls, they're falling prey to this problem. Because our evolution has been in thousands of generations. And what is happening in the last 1 or 2 generations is a tech revolution. And our evolution is not able to catch up with the tech revolution. That's why young people are getting into this trap. But it's more important to teach them, educate them, tell them where they really can avoid it and really have to correct their postures. And this is one of the important things. It has become a lifestyle disease. Under-treatment of pain is a pandemic. It's a global phenomena. But we, with good pain management, can really do justice for all these patients and can really put them back on track. They said it's cruel to deny people in pain to access to effective pain interventions. That's where Yashoda is doing its bit now. So chronic pain is a multidimensional issue. It's not just the physical pain which is there. It's a lot of functional, emotional, spiritual, and social aspect. And over and above in Indian setting is the financial aspect also, which is important. and especially with the bed earners get into this trap, the whole family gets into a problem. Patient needs help. We keep seeing these patients day in, day out in our clinics. Look at this patient. I call it it's a wrong on the part of the medical fraternity. If you allow patients to burn their back for want of the help, want of pain relief, it's not great. So I think probably that's where we fail, and we have to succeed thereon now. So the people have been doing, they get onto the painkillers themselves, they go to the chemist shop, and then they have analgesic nephropathies. In Indian subsetting, we have the diabetic capital of the world. If patients taking painkiller along with the diabetes, we are adding fuel to the fire. And then you really realize, and patients many times, they're getting intelligent now. If you tell them painkiller, they say, no, good. So, and another thing is GI bleed. We have gastro people around, they know how important it is to really educate people. They don't take too much of it because the acidity and everything comes up. And another bigger problem, which is the opioid pandemic, which is in the Western world, which is the painkiller which they tend to start now, they are going away from it, and it's a less and less opioid is being used. But sometimes people go for surgeries, good, but sometimes hard luck chases. This gentleman has gone for 3 surgeries at different times and still in pain. Look at this list, still in pain. So that what next? He's taken his last step and thereafter still in pain. So we have a provision, interventional pain management, doing good justice for these patients who are either going for advice for a surgery, we can really pull them out, or they are suffering because of the pain and you can really make them pain free. So that's the role of our pain specialists around. And especially younger people in this modern time, we have so many young people coming with the joint pain, MSK pain, and chronic pain scenarios. It is demography changing. What is used to be 30-40 years back is changing now very, very fast, very rapidly. Our kids and grandkids are falling prey to this. So let's pull them out and give them a pain-free life. Radiofrequency ablation, this is one good step to make them pain-free. Another is very vital, which you're going to hear today, very good topic on this, is regenerative combo therapies. We are trying to combo the pain relief along with the regeneration and repair. And we have so many molecules now available, PRP, GFCB, MAC, ACP, and exosomes and micromolecules are coming up. It's a very, very rampant new science coming and very, very helpful for the patients. So people are really doing good work with these molecules now, especially younger people. I'm happy. I told you, like many people go for knee pain. You can do a knee pain relief with the radiofrequency and regeneration with your all regenerative therapies. It is taken over the steroids. Steroids are bad in long run. And without any side effect of steroid, you can give them pain relief. And this is the platelet-rich plasma. It works from head to toe. It's not just one thing. In many athletics, many sports people are making use of this now. Celebrities also, so it is becoming into a fashion now. But yes, it is a relief. And initially people didn't believe, but you can repair things. That's something what you really want. You have your own body with you. And like in a frozen shoulder, people are having a pain. Physio, anyway, you have to do all this conservative management for 4 weeks first. But if it doesn't give you a result, there is a solution for that. And these are the frozen shoulder people. We can do the regenerative medicine, and you have a tennis elbow, and again you can do regenerative medicine. It's just a jab, just a needle, and we use 26 gauge needle, so it doesn't really bother pain, and relief is near permanent, by the way. And it can be repeated if need be, but it's a permanent solution. So here you are making your body anabolics. There's no catabolic inside the body. Lower back pain has always been a puzzle, especially lately. More and more people are with younger people coming into this, and you don't know. There are so many pain generators in the lower back, be it the facet, be it the lysis, be it the disc, be it the androgenic, and now we need to talk about the vertebrogenic pain. It is a new thing which has come, modic changes. It can cause pain. It was not there a few years back. There is a very good treatment, BVN ablation is there, which help these people. But it's important to diagnose what is the target, where is the exactly pain generator and targeted, and effective interventions are there. Spine injections are taken over all these big surgeries now, and who wants a knife? If you can manage needles, obviously, and that's the desired treatment for many such patients. Regenerative therapy for this disease, I told you younger people falling prey to this. If my son gets into this problem, I like to advise for regenerative therapy, then I'm going for any higher treatment modality. And that is it. And we are comboing it with the surgeries. If you're doing a spine surgery also, still we're comboing with the regenerative medicine. And even many orthopedic people who friends around, they know the regenerative medicine is giving a better result when they combo with the surgeries, even if it is open surgeries or endoscopic surgery for that matter. It's era of MAS, minimum invasive interventions is there. Endoscopy is doing a good justice for these patients. Like one patient who came with a foot drop, and there's a large disc piece in there, and patient had a foot drop. In one go, you just put in a scope 6.5 mm, take the disc out, and patient is walking back very next hour and walking back home and back to work by next week. Otherwise, if you leave them alone, these foot drop can be permanent for these people. These paralysis and all these injuries can be permanent. So you have to act proactively in emergency scenario if that is the case. He is talking about a friend of his. He is the friend we were talking about. With the first patient, we did the ultrasound, intradiscal ultrasound in the world, by the way, and we can name it after him, the procedure. So that's the ultrasound work. And once we did the procedure in the post-op room, and the very next hour is walking to the loo and look at this, is talking to his family and friends on the phone. That's a litmus test for these people. If you can give them pain relief, and they're back to their phones, they're glued to phone, that's wonderful for these people. Yes, we talk about failed back surgery, but also post-surgical syndrome. This gentleman had 6 open surgeries and 6 interventions, still suffering in pain. Going places from world over places, from Thailand to Egypt and whatnot places, and is not getting as a good pain relief. He came to me, and obviously the next best option is the spinal cord stimulations. We do have the spinal cord stimulation, DRG, PNS, and reactivated, which is doing justice. It's like pacing the spine, like we have a pacemaker in the heart, same way we pace the spine. And it really takes the pain away. It blocks the pain pathways, and that's what it is, like a gate control theory, where we got the Nobel Prize. People who are having a headache, we have some provision for cluster headache. We do a supranuclear ganglion block. But yes, it's quite often it's the trigeminal ganglion which is causing the problem, and it's a simple treatment. People are taking medicine for tens of years or decades and decades, and with one good intervention, they get the final relief, and which is for years together. Again, a repeatable procedure if need be, but mostly it is one time is more than enough. But it's realized they come from dental clinic after half the dentures are gone. That's not coming from the dental area. It is coming from the trigeminal area. So put in a needle here, block the trigeminal nerve, pain is taken care. But then there are some subset of patients who are orofacial cancer. India is the capital of the world orofacial cancer because of the tobacco chewing and other things, tobacco chewing, and they get these kind of things. They're dying, they know it, the death is imminent, they're seeing the death. But who wants to die every day? That's the whole problem. That's where you can really block this cycle of dying every day. You give them pain relief and they are back to family. That's important. I think it's the most human job you can do. And pain relief is more terrible than the death itself, and just sympathy is not enough. I've seen patients, relatives, even doctors standing by the side of the patient and just sympathizing or just looking at the patient, or put them a heavy dose of narcotics or sedatives, which is not good, and they cut off before they really die. And pain, pain warriors, they can fight against pain and put them to their families back. Celiac plexus is one of the problem. Treatment is there, because if there is anything gastrointestinal cancer, which is right from the gastroesophageal junction up to the splenic flexure of the large colon, be it liver, gallbladder, or pancreas, and you can give a permanent relief for the years to come for these patients. And I've done for this, even for the chronic pancreatitis patient, and you put in needle CT guided. We used to do fluoro earlier, and now this ultrasound is very, very big helpful for tool in these patients. And you can do in a cancer setting by the bedside for these patients. And you put in a needle, put in a drug, the pain pathway is closed, done job. And patient wants to go back home. And another thing is, like in a pelvic malignancies, or for the metroperitoneal malignancies, chronic pelvic pain, bladder pain syndrome, or dysmenorrhea, these patients, when they have the problem, you can do a superior hypoglossal plexus block. You do it fluoro guided, wonderful, done for ages, but radiation issues is there. Now we're doing an ultrasound guided block. A good ultrasound machine really makes the life very easy and simple. I told you, chronic pelvic pain is a problem of sometimes young ladies, corporate ladies, in active careers, very educated ones, and they have a pain in the pelvis, and they always think, they say it's a headache in the pelvis. And the problem gets bigger when the doctors, they don't believe. They say it's in your head. They don't believe it's in the pelvis. That my Euro friends are there, they would understand it's a very, very big problem. So there's a double pain now. Patient has got a physical pain and you're given a mental pain because you didn't believe the patient. And thereafter, and by the way, patient is looking for help, and patient feel helpless, all the more reason to, they suffer further on. The pain is real and treatable. Please, there is no merit in suffering. And with so many treatment modalities available, hypoglossal plexus block, impar block, pudendal block, and spinal cord stimulators, you cannot lose the battle if you have so many immunization with you. So you give them pain-free days, leftover days, or pain-free life thereafter. So you decouple pain, that's the whole point. You break the cycles, decouple pain, and mission is accomplished. You give them an easy life. Like a patient, young boy, I say God even cruel. I saw in a long time back in a cancer hospital, 5-year-old boy with the neuroblastoma. You see, God has given birth to take him back very soon. But then you have the catheter in place. It was a very big pain, howling. Who wants to see baby crying in pain? So put in a catheter, you put those Baxter's flexometric pumps, and you put the drugs in here. And for 4 months together, we could give him a nice, good pain relief to this child. Well, when you can't add days to life, the point is you start adding life to days. That's what it is for these terminal cancer patients. Please do justice for these patients, and you start gifting them smiles. This lady had a CA breast, and later on she developed secondaries in the liver. And this is just a month before she actually died. She's back with the family. So you're really gifting something back to these people. Another gentleman who came very recently, 6-level fractures, multiple myeloma, and then he was stooping, he was not even walking, and then almost cut off again from the life. And you put them 6 level, I did 4 kyphoplasty, 2 vertiplasty. It's a very high-end procedure, but very much doable if you do a good job. And patient got look at the patient face, by the way, my friends. Look at the patient face, such a smile. As soon as he off the table, OT table, right on the trolley, such a big smile. Well, I'm so happy, it's $1 million smile, I call it. So there's a novel plasma therapies are coming now, very, very new science. Let's put science into action. And we are burning the tumors away, and then we're refilling with the cement now, and you go to the post-procedure room and patients walking. What else you want for these patients? Sometimes life is limiting, but you want to give them quality in that limited time. With the age expectancy, we know it, we all are going to grow older and have osteoporosis. Some people have osteoporotic compression fractures coming up, even with tribal traumas. You have a patient fall in the Gurdwara, had a fracture, put the patient on table, put the needle in, cement in, and it's a quick fix for these fracture spines. Very effective, very good treatment, but unless patient realizes, doctor realizes, you can really put them back to work in a month time or 2 times. I've seen in US and other places, they do drive the car to the place, get the cementing done in 3 hours, go back home. So that's what we have to. I did a 6 level in long back 2010, and that was a record that time. Now people are just doing thereafter more and more of it. I have devised a technique. You can't do all this procedure unless you have a new technology. That I put a anti-epidural safety balloon behind the vertebral cortex, and I just put my cement work inside, and that's a safety. When you do all these high-end procedures, safety gets vital. It's like a pilot flying the plane, then you have a jet person flying the jet, so you have to have a safety in mind. I just show you a patient who's got a 6-level cementing, by the way, fracture spine, 6-level screws fixation is being done, but the fracture didn't unite, and patient was in pain. Put in a needle there, put the cement in there, and just do a nerve block there. Look at the incision size, the surgical incision size, and what we did from that small hole, and is the difference. And this could have been done with the small hole itself. Now there's a vertebral augmentation, and this lady, by the way, just to give you an idea, that this old couple, many of scenario, model demography, modern society, many people are loners now. Kids are gone and they're all alone, and they're going to grow old. And then going to have old age issues. She had a fracture spine. Look at the fracture spine, and the kids can't come back. They have their own life and everything. So the patients are left to suffer. Once they have fracture spine, you can't go to the washroom even. So what life it is, and it happens to the couple itself. It's not the person suffers. If the family suffers, then society suffers. It becomes our duty, pertinent duty, that what best we can do for these people to put them back on track and give them quality of life. And this is what I do with the same epidural balloon. I did a cementing in this lady. And well, the patient is happy, you are happy, and they're back to home, and again back to work, back to kitchen rather for this lady. So you are, by the way, God sent. I keep telling my friends here who are sitting here, and you're given a responsibility somewhere, that do your best, be your best, and deliver the best, so that you can really take the pain off the society, of these people who really need you most. Unless you do it, you deliver it, they're suffering around. I think probably I always feel that yes, it is our duty, medical duty and social duty, and over and above, I put it to myself, it's our human duty to give pain relief to such patients, if we can, if we should. And by the way, all these people are their liabilities. Old people, they are assets in the families. And once they get into sick units, they become liability for the family. And you turn those liability back to the assets. That's what we're trying to do, and that's what the whole thing is all about. The vertebral augmentation is a magic wand. With all these orthopedic fractures coming up, and I do it in burst fractures, vertebral planars, I do in retropulse fractures here, I do in multiple levels, and I do it in the retropulsing fracture, in the malignant fractures. I do it with my innovations. It is doable. Please, you can learn it, do it, and you have to be master in your game. Any game you play in life, you be your master and do it, deliver it. Why not? And that's it. And healing touch, keep gifting smiles and happiness all around. Some people, they are asking, what a pain, and they will beg for death. I have had people who are asking for suicide, and there have been instances because of pain. A lady died and she said, I want my daughter to be a pain specialist. That's the scenario, because pain is a pain is a pain. And then if you do a good work, then you have the smiles coming back. This lady had a foot drop. I did a procedure on her, and she was all fine. I'm very happy that her foot drop totally recovered 100%. I'm so happy for her. So let's keep igniting more minds, and we have to make this world pain-free. Through education, through knowledge, through skills, and through wisdom. And we have to do it as a pain relief is a human right. When I say pain relief is a human right, there is a second line. It is our duty to deliver that pain relief. It bounces back on me. Okay, if patient is asking for it, I have to deliver it now. It is my responsibility. So we can have those smiles all around, and we're not doing for ourselves. We are doing for generations to come, and we want to leave this world more pain-free, more efficient, and more effective. So it's a choice which patient has got. Either patient lives pain, or he leaves pain. So we always try to do our bit, one way or the other, which way or the other. I wish you all learn, take some message home, and please do your duty. We all together make the whole fraternity, medical fraternity is all about. So let's do our duty, and thank you friends for your time. Thank you so much. And thanks to sir and madam, putting up the whole show. I must compliment Sir P. N. Arora and ma'am, Upasana ma'am, and you did a good job. Thank you. So, the institutional sport is so vital.
Thank you so much, Dr. Neeraj Jain, sir, for this thought-provoking and visionary talk which you have delivered on the possibilities which are there to relieve the pain and making it a human right. Thank you so much. Now, moving forward, we are honored to have with us Dr. Sudhir Diwan, nationally and internationally recognized as a key opinion leader in the field of pain management, and he is the president for Advanced Spine on Park Avenue and attending at Lenox Hill Hospital, New York. Dr. Diwan was the former director of the Tri-Institutional Pain Fellowship Program and Division of Pain Medicine at Ivy League, Yale Medical College of Cornell University for more than a decade. In addition to that, Dr. Diwan has published numerous prestigious peer-reviewed medical journals internationally, and he is also on the editorial board for the Journal of the American Society of Pain Physicians since 2008. Dr. Diwan has been a recipient of many accolades internationally, including Global Educator by Latin American Pain Society in 2024, Trailblazer Award 2023 by FIPP, Lifetime Achievement Award of ASIPP 2022, and many more to know about. In addition to this, his busy pain management practice in New York City, Dr. Diwan has delivered extensive lectures and interactions regularly with experts in the field of minimal invasive spinal procedure, neuromodulation, and regenerative medicine nationally and internationally. With this, I welcome him on stage to enlighten us on the revolutionary topic of regenerative therapy in the future. Let's give a big round of applause for Dr. Sudhir Diwan.
While is connecting my computer, I would like to express my gratitude to Dr. Jain and Arora to give me this opportunity to be here. I think I remember Dr. Upasana, and we met a year ago and talked about this, and now I'm here. And I'm looking forward to really working with Dr. Jain and the group in a long time. This is good. So it was wonderful lecture by Dr. Jain, and what he talked about is what we do in our practice. By training, I was a surgeon. I actually was trained in surgery with 1 year in neurosurgery and worked in spine too before I moved to United States in 37 years ago. So for me, it was easier to really do more interventional pain medicine. When I entered in the specialty of pain medicine, we were considered as needle experts. And now we have come a long way. We are interventional spine experts. And not just interventional, we are minimally invasive spine experts. And as we move along, now we have regenerative medicine that gives an additional option to offer to our patients. So why regenerative medicine? Is not just to provide the symptomatic relief, but this is the only treatment option we have to offer to our patient that not only provides symptomatic relief, but addresses the root cause. Other than regenerative medicine, whether it's medication or surgery or whatever treatment options we have right now are not addressing the root cause. It's just helping for managing the symptoms. So this is why this is very important. Somehow slides are not moving. I think it's disconnected. Yeah. I think computer is not connected. Not connected to. I put in my laptop. Close. Start कर दो. हाँ बंद करके दोबारा रीस्टार्ट कर नो प्रॉब्लम. बंद करके रीस्टार्ट कर. कौन सा पीपीटी से? कौन सा है सर? Where is the PPT? हाँ. Last one. रीस्टार्ट कर नो प्रॉब्लम. Sorry for that. So that's why we offer regenerative medicine to our patients. And this is a short list of what we have. We have some commercially available cells, and we have some autologous cells that we take from your own body. And I personally think that autologous cells have much more to offer. Just keep in mind that regenerative process is a very slow process, and it takes decades to be symptomatic. What it means is that if you are using the regenerative medicine, do not expect things will change right away. It takes a long time, and that should be part of your conversation with your patients. The other problem is because it does take time, but there are ways to expedite the regenerative process, and that is because if you figure out how to deliver the cells or biologics where the target tissue is, and target tissue is where you are expecting to have some regeneration. Now, degeneration is like a ground zero. It starts with a small area where degeneration triggers, and then it slowly over the period of time, it spreads toward the periphery. It is a very slow process, but the bad news is it's progressive. It does not stop, does not go back to normal tissue, and that's where the problem is. Now, if you look at here, what you want is your degeneration to stop at 1 to 2 level, not at the level 4. If you can stop the degeneration at 1 or 2 or 3 levels, then you will avoid to have all these catastrophic complications that happen, including the spinal stenosis, can be prevented. And same thing is for the joints. If you can prevent the degeneration before it progresses, you can avoid these extensive surgeries. Now, very quickly, molecular mechanism, you all have learned in your physiology all this apoptosis and cellular senescence and the autophagy. Honestly, we really passed our physiology books and then we forget about it. But these are the situations that we have to learn more in detail, and we can actually prevent the contribution of this molecular mechanism towards the degeneration. The most important is that there is a triad of genetic predisposition, continuous microtrauma, and compromised nutrition. When these three works together, that is the setup for the progress of the degeneration. What really we don't pay much attention is oxidative stress. Oxidative stress is the imbalance between the antioxidants and oxidants, and this is where the problem happens. And on this oxidative stress, if you're obese, you get it. If you're a smoker, you get it. If you're under a high level of stress, you get it. So these are the normal day-to-day situations you come across that can be prevented, which contributes to oxidative stress. And oxidative stress is one of the biggest contributor to promote the mechanism of the cellular molecular mechanism. So it's very important to understand that. Now, joint is a complex biological system. It has articular cartilage, it has a synovial membrane, it has a subchondral tissue, and you have synovial fluid. Now, what happens in osteoarthritis is the joint starts degeneration, then there is no synovial membrane, and there is no synovial fluid, and there is no nutrition. So that is again the most mechanism that triggers, which is called cellular adaptation, is into subchondral area. And this is the topic of our today's discussion, is that subchondral area has been neglected for a very long time, whether it's in the joints or in the spine. That is the area that if you really focus to deliver your biologics, you will be able to expedite the healing process and the regeneration. This is the more like a basic science study looked at the targeting subchondral, and what happens is basically is there is a cartilage homeostasis, and cartilage homeostasis is a cross communication, cross talking between the cartilage, the subchondral bone, and the synovium. And that communication we have to re-establish when there is osteoarthritis or degeneration of the cartilage. And studies have shown that if you do the intra-articular and intraosseous or subchondral deposition of the cells, you will have a better results. This is one study of on hip, intra-articular and intraosseous infiltration of the PRP for severe hip osteoarthritis. And when you compare to intra-arterial alone or intraosseous alone, the intra-articular plus subchondral will have a better results. So I was speaking to some orthopedic surgeons here, and not just the subchondral, it is equally important to put your needle into the joint and push some biologics into the joints also. This is another study of 60 patients using PRP for intra-articular group and the intra-articular plus intraosseous or subchondral group, and the second group did much better with PRP at 12 months follow-up. Then there are more advances. Rather than putting the needle in one subchondral area, joint has two subchondral area. So put the two needles, and this actually has done two needles, one for the femoral subchondral and one for the tibia, and has better results. The problem here is, yes, if I'm doing the two subchondral and one intra-articular, and if I like it and my patient doing very well, I'll always talk about it. But I really don't know scientifically whether my procedure is better than doing one subchondral unless I compare. And that's one of the flaws that we have in our system and our research publications, that I suggest you all, when you read something, take a very critical look at the manuscript and see what's going on. Because most of the manuscripts have a problem is the small sample size. You cannot really learn anything from 10, 20 or 25 patients. Do you know the opioid crisis that happened in the United States started with 36 patients? Just one article, pilot study, 36 patients using the opioid for non-cancer patient, and you can see where we ended up into. So sample size is very important, and bias is very important. If I'm using cells that I like it, I'm going to talk about it. But if you compare, then you will know which one is better. So let's talk about the disc now. This is the functional unit, if you can. The disc, the vertebral, the bodies, the end plates. The disc is the largest avascular structure in the body, and the nutrition for the disc comes from the vertebra by diffusion through the end plates. What it means is, if your end plate is calcified or fractured, disc is not getting the nutrition, and that is another setup for progress of the degeneration into your disc. So the spine even looks pretty good on your left side. When you don't take care of, and when nutrition is compromised and trauma keeps happening, then this is what happens. Your disc becomes very small. You are bone on bone. You put in a lot of pressure on posterior elements. You have spondylosis, spondylolisthesis, you have spinal stenosis. All the disastrous complication starts from one small degeneration that we didn't stop. Now, use of biologics has multiple evidence in the literature. First, most important is the safety, and the article left side is on the basic science, and this is on clinical science. And both this metastatic or rather the systematic reviews showed that it's safe and there is no really any risk of tumor or anything like that. Then you have the American Society of the Interventional Pain Physicians published this evidence that shows the intradiscal injection has level 3 evidence and intra-articular level has level 4 evidence. So level is there, the evidence level is not very high, but it is there. And then there are many this is systematic review and meta-analysis. This is another systematic review. And then there are the evidence that where the PRP or stem cells has been used. The only one problem here is that all these cells are used for mostly lumbar area. We do not have, I found only one study that is done on cervical, but there is no literature on thoracic disc, no literature on cervical disc. And in my practice for last 10 years, I started with lumbar disc, but now I do lumbar, thoracic, cervical, intra-articular, intradiscal, peridiscal, subchondral, all these areas I do. So how I started, this is the article that was published by a spine surgeon from California, and he only did work on 26 patients, and he followed at 3 years, and he injected only 2 cc of the intradiscal bone marrow concentrate, and out of 26 patients at 3 years, only 6 patients went to surgery, 20 patients did not require surgery. And after followed at 5 years, also they did not require surgery. So it was working very well. This is another article came from the Ohio, from one of my friend who is an anesthesiologist, he did, and this is sample size was 80 patients, and that also showed very positive results. So we do have a lot of evidence in literature. If you look at it, problem is because of the sample size and all other issues, the grading of the level was very low. Now I want you to understand this slide very, very well. We have, patient comes to you for symptomatic relief. Patient doesn't care whether there is a degeneration or whatever problem, as long as you can help for the pain. So in other words, you have to very clearly understand what to inject and where to inject. Because if you are looking to treat the degeneration, then you have to inject the biologics into the disc, because degeneration is the central process. But if you are trying to help patient for the symptomatic relief, then injecting the intradiscal is not going to help, or it may help, will take years to help. The patient cannot sit for the symptomatic relief will happen only if you inject biologics into the peridiscal area, because inflammation is a peridiscal, not a, so where to inject is equally important, as important as what to inject. So these are some of the cases. If you can see in my practice, this is very advanced. This disease, you can see there is no really disc left, there is no end plates, and this patient actually is still doing very well. This was done like 6-7 years ago. My point is that it does help and does work. You are not going to make the spine like she or he was in 30s or 40s. But if you can help for symptomatic relief, and the patient can go and enjoy their social functions and dinners, then they are very happy. This patient was actually from Russia, and these are thoracic disc, 6 levels I did. Usually I don't do more than 3. But I was kind of convinced because patient was coming from outside and couldn't stay in the city for a long time. This patient also on the list for surgery, and now it's almost 3 years, she's still doing very well. And this is cervical disc. This is a patient from Mexico. She was on the list for cervical fusion, and her doctor is my friend in Mexico, sent her to me. It's 6 years I did cervical, intradiscal and peridiscal BMAC. She did not require surgery. So it does work. Now, one of the things that I want to bring up is that there is those who work in the spine, we always tell that the best treatment option will fail in the disc. But that's not true. It's because we were not diagnosing proper. If you have wrong diagnosis, if you offer a wrong treatment, it is going to fail. So what happened in the last few years is we learned that the modic changes caused by the fracture and calcified end plates is causing the vertebrogenic pain. Vertebrogenic pain is easy to treat. You put just like you do kyphoplasty, put the cannula into the vertebral body and use a bipolar radio frequency for 6 minutes, and it will take care of your pain. This is actually my favorite procedure. Patient comes in a pain, goes home without pain, almost without pain, and I do it on my regular basis. These are the options we have for vertebrogenic pain. Is intraosseous, which is put the cannula into the vertebra, extraosseous or intraosseous or extraosseous biologics. And studies have really shown that it on a long run, this is a 5-year study, Intercept, and has look at the results. And 1/3 of the patient, this is only treatment I offer to our patients, 1/3 of the patient at 5 years were treatment pain-free, which is you don't really see in pain world where any patient would be pain-free. Just 33% is pretty good. But we want to go beyond that. As you know, the modic changes causes the calcified fracture end plates. The fractured end plates, advanced degeneration causes segmental instability. And this is where we should really focus on, that if we put not just intradiscal, but also put the subchondral biologics, you can help the disc and you can also help the end plates. And if you help the end plates to heal, then you can also improve the segmental instability. So it sounds like no, it's not possible. This is very much possible, because all my patients that I have done subchondral, they are so far doing very well. You have to understand the degeneration takes 3 to 4 decades to be symptomatic. It also will take some time for objectively to see on your studies whether the patient has responded very well or not. It heals the disc, it heals the end plates. The end plates, when it fractures, all the inflammatory going to the vertebra stops and the inflammation is under control. This is one case where the PRGF, which is platelet-rich growth factors, which when you take the platelets and activate outside the tissue, this is what you get, and that was injected. This is just a case report, but you can see within 6 months, patient had improved the changes in the MRI, which is very, very encouraging, because usually it takes 2 to 3 years. And this is 6 months, so subchondral I think is way to go. So this is the intraosseous PRP for chronic lower back pain, retrospective review of the 57 patients. Almost 60% had modic changes, and out of the 42% received PRP, and 96% patients who received PRP with the modic changes did very well. So there are more and more results coming out about subchondral injections and improved results. This is my assistant. We are doing the bone marrow in my office. These are all MRI proven advanced cases of the degeneration with the end plate degeneration. This case one was the 72-year-old male. We did, now what I do, I mix the treatment options. Some patient I do intraosseous radiofrequency for immediate pain relief, and then I do the subchondral injection of biologics, or I would do both at the same time. Now in a New York City, based on the insurance, our practice somewhat changes. If insurance would pay, then I'll do the radiofrequency ablation into the surgery center. If insurance doesn't pay, then I'll do it in my office because it is more cost effective, and I also get paid more if I do it in my office. So this is for 6 months, 75% pain relief. Very similar case to 6 months, 60%. This patient had the radiofrequency in the surgery center, and then after 2 weeks came to my office, and I put the bone marrow concentration, subchondral, intradiscal, and peridiscal. This is third case. This is actually a very interesting case. If you look into the MRI, it does not look that severely advanced, but had a severe modic changes. We did multiple epidurals, didn't work, radiofrequency didn't work. Then I did, and I convinced him, and then he agreed that we should do this. And now he had actually canceled epidural because he doesn't need anymore. He's 80, he's, how old is he? He's 80 something, 81-year-old male. So anybody from here has visited Cuba ever? Anybody Cuba? So in Cuba, in between, late 50s, America used to send all the cars, all the American cars. Then because the political problems, they don't have the cars anymore. So what they do, they keep revising the cleaning and fitting the car. And this is what happened. This is the car actually I drove. It drives like a new car, which is a 1952 Chrysler. So point is that if you really prevent the degeneration, which is the ground zero, you will not need any extensive joint surgeries or extensive spine surgeries. And this is actually not anything against the surgeons or surgery. This is for mankind, that we all will get stenosis, we all get degeneration. And if we can prevent it, then we can avoid all the surgery. So stay tuned for a lot of studies will be done. I have a couple of studies going on, and next time if you invite me, I'll give you some more results about these studies. Thank you very much.
Thank you so much.
Thanks. Thank you so much.
Thank you so much, Dr. Diwan, for your powerful insights and your passion for advocating a cause that resonates deeply with us all. In fact, everybody of us, or either ourselves or somebody in the family, would be facing this low backache, knee pain. And with your insights and your suggestions, we are actually into a thought-provoking stage wherein we can think about that without surgeries, the pain can be relieved. Thank you so much, sir. Among us, now we have one of the dynamic, renowned, and very senior consultant of internal medicine. Dr. Arora is with us on this evening, and it's my privilege to welcome him on the stage to do the word of thanks on behalf of Yashoda Medicity. Dr. Arora, sir, thank you so much. Over to you.
First of all, thanks to all the people, my colleagues and seniors who took out time to be there on Sunday evening. And my special thanks to Dr. Neeraj and Dr. Sudhir for coming all the way from USA and giving us the knowledge and the wisdom of the new era of medicine, because we all have gone through this degenerative phase and we will be going through degenerative phase. To prevent this degenerative phase, yes, this will add to the life. We are increasing our life expectancy, so living life without any disease, and this is the way you are telling us. We should avoid more and more of surgeries, and by giving people a healthy and happy life so that they can walk without any pain. And as Dr. Neeraj has said rightly, either live with pain or leave pain, and we have to leave pain and give the best, whether we are giving in terms of pain relief therapy or whether we give in terms of regenerative therapy, whether we are using biologicals or whether we are using stem cell, whether it's pluripotent or unipotent or multipotent or whatever stem cells we are using to regenerate that subchondral part and to prevent this damage. So thank you very much. My special thanks to Dr. Sudhir and Dr. Neeraj for being here with us. And it's my privilege to thank you, our chairman, Dr. P.N. Arora sir, MCMD Dr. Upasana ma'am, and for bringing us the people together on this Sunday evening. Thank you very much, and thank you all. Thanks. My request to all of you to be with us for a small cocktail and dinner. And if you have some queries, then these queries can be cleared by Dr. Neeraj and Dr. Sudhir on the dinner table. And please join us for dinner. Thank you.
Please join us. Thank you so much. Thank you so much to all of you.
Thank you.